Hi everyone, Dave Bosch here. I'm going to put together a several-part series on how to increase your ED throughput by using ultrasound at the bedside. Usually I have people have concerns that ultrasound used at the bedside slows them down, but I have a couple instances where I think it really will speed you up. The first one we're going to talk about today is first trimester vaginal bleeding. So to start, I wanted to talk about the key elements that we need to get through in a patient presenting with seemingly simple first trimester vaginal bleeding. We all know that a lot of these people are nervous about a pregnancy with maybe some spotting that's occurring, maybe some spotting after intercourse. And so this really pertains to the well-appearing first trimester vaginal bleeding patient. So we want to talk about several different things and do a checkbox analysis to make sure that we're not missing anything. So first of all, we want to check for, obviously, their clinical stability, so they must have normal vital signs. We want to assess their degree of bleeding. We want to find out if they have an IUP, and then we want to do an investigation to see if they have RH positive or negative status, to see if they need any further treatment, and determine if they need a BTG or not, and then determine if they need urgent follow-up with OB. So my recommendations before you go into the room would be to check the nursing triage for vital signs. I get into the chart and typically try to find previous RH status, and then try to find if they've had a prior documented IUP, because this will actually help you to know how far they are along. Based on the triage reports, I'll estimate or guesstimate the gestational age, because if the patient tells me or tells the nurse that they are early in their pregnancy, like under 5 or 6 weeks, then I typically am not going to waste my time with an ultrasound at the bedside. Transabdominal views are really difficult, even in really thin patients under 5 or 6 weeks. So keep that in mind. Just as a reminder that if the patient is RH positive, then they don't need ROGAM. Then we're going to grab the ultrasound machine and head into the room. Turn the machine on and let it warm up while you're talking to your patient and confirming a couple key factors, such as their RH status, their OB history, and then just double checking to see if they've had prior ectopic pregnancies or if they're on any fertility management or fertility treatments, as this will make them high risk for ectopic or heterotopic pregnancy. I do my physical exam, and then as I'm doing my physical exam, I typically pull out the ultrasound machine and combine this into my physical exam. And unless there's something really strange happening, I typically don't perform a pelvic examination. So next we're going to do the bedside ultrasound. We're going to look for several different features with the ultrasound, and I'm going to go through them one by one. The first, we're going to determine whether the pregnancy is located within the uterus. This might seem simple, but you want to look through the abdomen in both the transverse and the sagittal planes, and identifying the uterus, and making sure that the intrauterine pregnancy, the gestational sac, is located within the body of the myometrium of the uterus and not tucked up into the cervix, and not off to one side or the other. Next, we're going to identify the gestational sac. A gestational sac, again, is this first sonographic finding of early pregnancy, and it's just a simple fluid-filled structure within the uterine cavity. On the picture to the right here, there is the large black circle within the myometrium that is the gestational sac. Within it, you see both the fetal pole and the yolk sac identified. So next, we want to identify the yolk sac. The yolk sac is this small circular structure within the fluid-filled gestational sac. Okay. After you identify the yolk sac, you identify the fetal pole. This is typically a small portion of fetal embryo tissue that comes off the side of the gestational sac. It's typically easily seen, and this is where you could, as early as a couple weeks, measure a crown rump length. Next, you want to identify a fetal heartbeat. Most of us are comfortable doing this with the typical M mode way of doing it, by putting the cursor of the M mode beam over the heart rate and then hitting M mode again. You'll get a waveform at the bottom of the screen that will be quite a bit faster than the patient's heartbeat, and then you can pause the screen, go into the fetal heart rate tracing, and then go either from peak to peak or valley to valley, and then it'll give you the fetal heart rate at the bottom of the screen. Next, you want to look for the absence of free fluid in the cul-de-sac. If you have a patient with a lot of free fluid in the cul-de-sac, such as in this picture to the right, then that might be something to investigate further, as the patient might have a ectopic pregnancy or a heterotopic pregnancy, ruptured ovarian cyst. There's a lot of different things that can be occurring at the same time that you might want to investigate with a consultative ultrasound. Well, wait, what about the beta? Well, if you have an IUP on your bedside ultrasound right off the bat, and you don't really have a concern for an ectopic pregnancy or heterotopic pregnancy or anything else unusual, then you don't need a beta HCG because you've now confirmed that the patient has an intrauterine pregnancy. So it's really not all about speed. When we talk about ED throughput, I want to show you a little bit of the differences in timing between what you can accomplish with a point-of-care ultrasound versus going through radiology department and drawing potentially unnecessary labs on well-appearing patients. So the way I do this is I check the patient when they arrive, and I look at their triage notes while the patient is being triaged and roomed, and maybe this takes 10 minutes. I go in and do my history, my physical exam within about 5 minutes, and combining that with an ultrasound will give myself maybe another 5 minutes, although it's probably more time than I actually do. And then if everything is normal, so the patient is a normal human with normal OB history, and they have a simple story of spotting and no heavy bleeding, and they are Rh positive, and they have a normal IUP on ultrasound, then I'm going to sit with them for another 5 minutes or so and talk to them about how I have reassuring findings on my examination, and that I think we can send them home and have them follow up with their OB/GYN. Contrast that to somebody who gets sent through the radiology algorithm and maybe doesn't get the investigation right up front. So maybe the patient arrives and gets triaged and roomed in the same fashion, and you go in and do an HMP, but you've maybe already just shotgunned some labs, and so they've already gotten somebody in there, they've already drawn blood and sent off a CBC, a basic, and a quant. Then you send them for a diagnostic ultrasound. The labs take 30 to 45 minutes, maybe longer depending on the day. Ultrasound, depending on the location, the time of day, can take anywhere from 60 to 90 minutes. So say you get all that back, you get a quantitative HC that's 50,000 because you've got a patient who's 8 weeks pregnant, and then they come back with an ultrasound that shows a simple intrauterine gestation at 8 weeks. You go back and have the same discussion with the patient that they've got an IUP that looks normal, and they're going to follow up with their OB/GYN. This can take, sometimes 2 to 3 hours, depending on, again, the day and the situation that the ED is in at the time. So I do want to just show a couple pictures of some abnormals. The most common abnormality that we're going to find is a pseudogestational sac. The picture on the left shows a pseudogestational sac, and simply it looks like a regular gestational sac, but it's not specifically in the endometrial lining where it should be, and there's really nothing else in it. So if you were to zoom in or try to take some other pictures of this, really you would find an empty sac, and this can be associated with an ectopic pregnancy. This can fool you pretty easily if you don't do further investigation into the yolk sac, the fetal pole, and then looking for a heart rate. On the right, you can see what's called a cervical ectopic pregnancy, and so as you see here, the fluid collection that you might talk about, this is a gestational sac, but it's way high up in the cervical canal. And so it's not really located in the normal area of the endometrium. And so this would be highly unusual as well. So big picture, we really don't want to miss an ectopic pregnancy in these patients. For the purposes of us in the emergency department, we want to focus on patients that have demonstrated a clear intrauterine pregnancy. So that includes a yolk sac, a fetal pole, and or fetal heartbeat in a pregnancy that's in a normal location in the uterus. Anything that falls outside of that, you need to get a consultative ultrasound, because that's a pregnancy potentially of indeterminate location. So if you're not confident, don't worry about speed. Worry about the patient. I always tell you that the patient care comes first, and we don't have to worry about all these other things with ultrasound. The purpose of this presentation is really to focus on the simple, straightforward patient who's in the emergency department that needs very little testing, needs reassurance, and needs to be sent back to their OB/GYN for outpatient follow-up. So that's it for today, guys. If you have any questions, please always feel free to reach out to me and with questions. We'll do a couple other ultrasound demonstrations and videos for other ways to speed you up through the department, and I hope you guys are well. Thanks.